first do some housekeeping and reminders, and then, if it's your first time joining us, we'd absolutely love to meet you. Please put your name in the chat and anyone who's joining with you. Today, we are really fortunate. We have a didactic in two parts. So the first part really focuses on dementia risk reduction, and the second part is kind of the practice transformation. How might we implement some of these recommendations around positive behavior change in a busy primary care clinic? And we're very fortunate to have Dr. Jacob Mirsky, who's going to talk about his program within primary care called the Healthy Living and Lifestyle Program. And I'll be talking about dementia prevention targeting modifiable risk. And then hopefully this will engender quite a lot of discussion. And if we have time, we might do a breakout and an exercise. We'll see. We'll see how the timing goes. So please put your name in the, as I said, rename yourself and put your name in the chat, mute yourself when you're not speaking, and then unmute. If you can, we'd love to see your faces. We understand if we can't, of course, but we do love to kind of see one another in this community to build and get familiar and support each other. And if folks are in the same room, do add everyone in the chat. So this is a relatively new shift for CME credit. So for all UW faculty, staff, and students, do please complete this mobile text registration and sign in. So you see the number here and register. And then at the end of our session, you can text the 8574 to this number. And then you should receive a text response saying, thank you, we've recorded your attendance to the Dementia Echo for the CME. Okay. If not, you can reach out to Sammy to ensure that, or actually she's recording all of your attendance through our Zoom analytics. So make sure that you're displaying your full name. And so Sammy can reach out in the chat if she needs additional information from you in order for you to have this CME for your time and engagement. As we've reviewed in the past, there's a number of echoes that are happening through the University of Washington around traumatic brain injury, around addiction, a number of series. There's a hotline for deprescribing for people on high-dose opioids, and then there's also a CME accredited case conference around telepain. In addition, there's the psychiatry grand rounds, which are archived and which you can view whenever you'd like. We're still collecting information for the survey from the Dementia Action Collaborative. So take a picture here, please do join. We need to better understand what are some of the barriers and challenges of screening, diagnosing, and caring for people with dementia. We really appreciate your time, your feedback, and we learn so much from your experience. For case presentations, of course, HIPAA compliance, protecting PHI, we would don't ever display or reveal anything that could be personal information such that we could identify. And remember that all sessions are recorded and available on the website. Please do complete the 1-minute survey. Again, it helps us to improve this process with you and for you. Our upcoming next session is March 8th, and Dr. Ariana Tart-Zelvin is going to be talking about neuropsychological assessment and diagnosis of dementia. And we have another, as you see, a number of exciting talks following. We know, again, you're a vital part of our community. Please do bring cases. There's no case that's too simple or too complex or too soon or too late. We all learn together when we bring our cases forward. We have CME accreditation. We have no financial disclosures. Here's our hub team smiling at you all. And as you see, we really kind of represent a number of health systems across Washington and a number of experiences and expertise. We've provided almost 1,500 instructional hours since the inception in June of 2020. Over 70 of survey respondents said that they would plan to make a practice change based on the learnings. And we really want to continue to grow to kind of build and scale dementia capable care throughout the state. So if you know of somebody who may benefit or perhaps is interested, please sign up or contact Sammy. All right, so I'm going to dive right into my talk. I don't need an introduction. I'm Nancy Isenberg. I'm delighted to be here to talk to you today about dementia prevention targeting modifiable risks. So the objectives today are to identify 5 modifiable risk factors for dementia across the lifespan, to develop strategies to emphasize the overlapping risks and prevention approaches for heart disease, stroke, and dementia, and perhaps to practice motivational interviewing skills for risk reduction and dementia prevention. We'll see if we have time for that. Okay, so I'm going to start with a delightful story. I had a patient who came to my clinic the other day, and she was almost 96 years old. And she sat down and she shared with me that she had the recipe for her long life. And what she shared was the 3 W's. So her 3 W's were water, walking, and weightlifting. And, you know, as she shared, she was really very engaged. You could feel her sense of purpose. You could feel her why. You could feel that she had found her what matters. And so, you know, her 3W is kind of a lovely, concise description of how she found purpose over her lifetime and how she stayed active and engaged. And then if we flip the W to the M, or we have a different perspective, of course, that's our, you know, 5M age-friendly health system. So Carrie Riebenstein gave a great talk about this a couple of ECHO sessions ago, and it's a very important way to sort of organize, in particular, the annual wellness visit with these 5Ms. So fundamentally, you know, how can we connect with patients around what matters so we understand and know their preferences, and also really who they are. You know, we do careful medication evaluation and reconciliation, so we're minimizing anticholinergic burden. We're assessing mentation for mood and cognition and delirium. You know, how do we keep people from becoming frail as they age? And how do we optimize nutrition? And these are massive questions, of course, but they are really important to think about in the annual wellness visit, and broadly speaking, if we want to really have an impact and get upstream for dementia prevention as well. Okay, so, you know, how do we define brain health? Brain health is newly defined as a state of brain functioning across cognitive, sensory, social, emotional, behavioral, and motor domains that really kind of allows a person to access their full potential over the life course. So along the lifespan. And more importantly, this is really irrespective of the presence or absence of disease, and seen through the interconnected social determinants of health. So, and Vladimir Hachinsky has really been a pioneer in this space in redefining brain health as well, and to kind of connect heart health, dementia, stroke prevention. So this is a paper that he co-authored back in 2022, where he really asserted that we need to come up with a comprehensive, customized, cost-effective approach to the prevention of, again, linking stroke, heart disease, and dementia. What are the protective factors to promote eumentia rather than factors which can, you know, increase the risk of dementia over time? And you know, these have many kind of levels. They have individual levels, there are policy changes, there are environmental factors, of course, socio-political, economic, and so forth. But really, how can we, as a society, and then in our clinics and in our health systems, promote eumentia, this optimal cognitive, mental, and social functioning? That's really what we're trying to kind of reflect on today. And so again, you know, brain health and shared risk factors, there's so many overlapping risk factors for stroke, dementia, and heart disease, such as hypertension, such as diabetes, such as smoking, such as obesity, such as being sedentary, such as poor diet. And we know, you know, hypertension is the most significant of all, and 1 in 3 of middle-aged adults has hypertension. It's predicted to be 1 in 2 by 2025. So not a small number at all. This is familiar, I hope, to most of you. This is the Lancet paper that came out, which, identified that 40% of dementia cases are preventable over the lifespan. That's a very high number. There are non-modifiable risk factors, of course, such as age and family history and genetics and ApoE4, which we cannot change. There's epigenetic modulation of ApoE4, we know that, and I'll show you some data on that later. But so in terms of the 40% dementia risk, we know that lifelong learning and high cognitive reserve is neuroprotective, and lower levels of education increase the risk. Hearing loss, traumatic brain injury, hypertension, heavy alcohol use, obesity, smoking, depression, social isolation or loneliness, physical inactivity, air pollution, and diabetes. And so we're going to kind of do a deeper dive here to kind of unpack what has been studied around approaches to target those risks, looking at outcomes over time. And we also know that in America, 6 out of 10 adults have one chronic disease, and 4 in 10 have 2 or more chronic diseases. And as you see in terms of these chronic diseases, I mean, diabetes, kidney disease, stroke, and heart disease all increase the risk of Alzheimer's or mixed dementia as well. Okay, so mixed dementia. So we know from a study in brain that came out in 2021 that, and we've known for some time actually, that really it's the rule, not the exception, that when you look at autopsies, that most people have mixed pathology. In fact, 98% of early onset cases with 2 pathologies, and about 100%, everybody basically who had late onset had 3 pathologies, one being cerebral amyloid angiopathy, the other being Alzheimer's, and then Lewy body. And the most frequent that was seen was mixed with Alzheimer's and vascular dementia. And certainly this is perhaps less common in tertiary or quaternary dementia clinics where people present younger or they present with more atypical cases. But the patients who you're seeing in your clinic in these community samples, it was more than half of all patients had mixed pathology, and over 90% had periventricular lesions as well. We also know that, and you see here in this study from 2022, in terms of how long we can live without developing Alzheimer's disease, that if you incorporate 4 or 5 of these positive health behaviors, you have a longer proportion of life without Alzheimer's disease. So these are non-smoking, exercising more than 150 minutes with moderate to vigorous intensity, light or moderate alcohol consumption, high quality, I would say whole food, plant forward diet, and then, staying engaged in cognitive activities. And this was self-report. So they may be going to the museum or playing bridge, those types of things. And if you had 4 or 5 factors, it reduced your risk, 60% lower risk. Now, what you'll see here in terms of men and women, we know that 2 out of 3 people with Alzheimer's are women. And you see that the slope, even for people who had 4 or 5 healthy risk factors, is steeper in women who, they are going to get dementia more than men who can live longer with these 4 or 5 health risk factors over time. Okay, making sense here. So this study actually just came out, as you see, and what they were looking at was healthy lifestyle and cognition in older adults with common neuropathologies of dementia. And so they looked at 586 brain autopsies of people who had a mean age of 90, so quite old at the time of death. And what they found was that lifestyle habits were linked to dementia risk more than amyloid plaques or abnormal blood flow in the brain. So about 12% of cognition-related measurements were affected by the amyloid plaque, whereas smoking, at least 150 minutes of physical activity, limited alcohol, this healthy whole food plant forward mind score, and cognitive activities were neuroprotective. And the higher folks had of all of these, the lower their risk of having dementia over the time that they were followed. Here, from the same group, looks at 2 longitudinal studies, similar 5 kind of domains. And what's important to note in this study is that this is quite a diverse population. So of these folks, 4 or 5, there was a 60% reduction overall over the time of this study incorporating these healthy lifestyles. So a number of observations, autopsy studies, people followed prospectively over time, and just one more study demonstrating that, our genetic risk to have dementia is about, at the population level, is about 60%. It's sixfold if we have an unhealthy lifestyle, and we can cut it by more than a half if we start to incorporate these healthy lifestyles that I spoke about. Here is a study looking at the UK Biobank, which is a massive data set. And what they found looking at this, McCann's brain care score, which was actually developed at MGH, and which I think Jacob might speak about in his talk. So what they did is they had people fill out these domains. So in physical activity, lifestyle, and social emotional activity or engagement. The higher the score, the more neuroprotective. So as you see here, over time from the biobank, the cumulative incidence of dementia, stroke, and risk stratified by quintile, the people who had the highest level in terms of, healthy nutrition, moderate to low alcohol, they weren't smoking, they were active, they were sleeping restfully 7 or more hours a night. They had stress resilience, they felt connected, they found purpose, their BMI was low, they had, healthy cholesterol level, their A1C was less than 5.7, and their systolic blood pressure was less than 120. These were all gave you high scores. And in this, if you were in the fifth quintile with your high score, your risk over time, cumulative incidence over these 15 years that they were followed, was really quite low for dementia, stroke, or stroke and dementia. Okay. So, I am boarded in lifestyle medicine. Jacob Mirsky is also boarded in lifestyle medicine. And we think about these 6 pillars of health. We think about nutrition, sleep, social connections, physical activity, stress resilience, and substance use. And so in terms of looking at, how can lifestyle medicine target and reduce dementia risks, cerebrovascular and cardiovascular disease, stroke, and vascular cognitive impairment, and I would say mixed dementias broadly, we know that, and it has been studied quite extensively, 3 common diets are really neuroprotective, whole food plant predominant, really neuroprotective. For sleep, if you have untreated sleep apnea, your risk increases both for stroke and for dementia, prolonged insomnia as well, and interrupted sleep. So people who work shift work. Physical activity, we'll do a deeper dive, but we know that for high physical activity, there's a significant risk reduction for stroke compared to inactivity. And then stress management, I'll show a recent paper that came out looking at Tai Chi, but stronger association with better controlled hypertension, and non-smoking, very neuroprotective. All right, the Sprint Mind trial was published some time ago and demonstrated that with aggressive or intensive blood pressure management with a systolic less than 120 was associated with a decreased risk of the development of mild cognitive impairment over quite a long time period, over 6 years. Subsequent papers demonstrated fewer white matter lesions or hyperintensities, larger whole brain volumes, and there was no difference in stroke risk in subsequent analysis. So there's been many meta-analyses looking at physical activity or exercise, and really any type of physical activity has been demonstrated to reduce the stroke risk and the progression of cognitive decline. We know that it promotes neurogenesis and neuroplasticity, it reduces neuroinflammation, it's neuroprotective in a variety of mechanistic ways. So I know this is quite a busy slide and you can go back and look at it, but what I wanted to demonstrate here with regard to the amyloid burden is that when people started to exercise, they reduced, first of all, okay, so these are people who have low amyloid burden. These are folks with high amyloid burden who did not exercise, and their cognitive scores over time declined, whereas people who had both high and low amyloid burden, but who did exercise, had similar cognitive scores over this 8-year period. So it was demonstrated that physical activity moderates the association of amyloid beta with cognitive decline. This is a sort of a description of the various ways that the systematic or systemic effects of exercise. And we know that the exerkines that are released from the muscle and the liver, like irisin and IL-6, can go into pass through the blood-brain barrier and promote this synaptic plasticity, neurogenesis in the hippocampus, reduce neuroinflammation. So really, there's just so much sort of biological evidence and meta-analyses of studies in humans to really demonstrate the benefits of movement on the brain. This was a fascinating study that was really recently published. It's a randomized clinical trial with people in middle age who were followed over 12 months. And they looked at people randomized to either Tai Chi or aerobic exercise, which was vigorous walking. And these were people who were pre-hypertensive in midlife, as I said. And what they actually found was that people did better randomized to the Tai Chi group. So, 25% almost of people in the Tai Chi group versus only 16% in the aerobic group became normotensive. And of course, I'm not saying by any means that we shouldn't speak to our patients about exercise. However, what I am saying is that these mind-body practices that promote vagal tone are also really helpful when approaching people with midlife hypertension. Okay. So as I said, many meta-analyses over many years, and as we said, multiple mechanisms of action. We know it helps for cognition in terms of improved processing speed and executive function far more than memory. We know it helps to prevent the frailty. It preserves independence and mobility. It can help us to sleep better at night. So we can, and I refer you all to Lena Fine's fantastic talk if you want to look at sleep in relation to cognition and dementia. And, it can also really be a lift in our mood. So it's most likely beneficial when it's combined with other approaches. And the strongest, most robust evidence is really for, primary prevention. So we're getting very upstream today in these recommendations compared to some of our other recent talks. So the most, the best benefit is for primary prevention, but there are studies demonstrating utility and impact in MCI and even in dementia. And we have learned that, working within a group where there's accountability and support tends to be more beneficial than at the individual level. And there's evidence that it can be beneficial across multiple settings, virtual, home-based, and so forth. Okay. So, what do we recommend? Well, I hope this is familiar with most of you that we recommend, 150 minutes of moderate intensity or 75 minutes of vigorous intensity per week. In addition to that, we recommend strength training twice a week. And this is from the American Academy of Sports Medicine. And, if there are limitations, then adjusting those accordingly and finding accommodations, of course, as well. So this study I thought I would also share, which came out like really recently, and what it found, and this is around all-cause mortality and cardiovascular mortality. So it's not about dementia per se, but it's about living longer. And women in this study, it was found, and again, this was a massive study with a number of people. I mean, I think over 300,000 that women had to exercise 140 minutes per week compared to men. Their benefit was conferred with more exercise. It's one of the few areas where we get to do a little less for more benefit, but it's an interesting study, and you can take a look in more detail. I don't have time to go into it in more depth right now. So then how do we do this? What's the how do we talk with our patients and support our patients to exercise? Well, it's with a shared conversation, of course. So how do we structure that? How do they make themselves accountable to showing up? Is it with a trainer? Is it through a diary or a Fitbit? There's many different ways. And there's not, of course, never is a one size fits all. And how can we incorporate, motivational interviewing and SMART goals? And how do we kind of set it up for success with well-paced incremental increases and graduated and so forth? Okay. So thinking about, okay, we've talked about why I think it's beneficial. Why do you want to do it? What are you drawn to? What would be fun for you? What would be interesting? What do you think you would enjoy? What matters to you? And then we know that it's beneficial to do it it can be done in bursts, like an instant recess or exercise snacks. And even at your office or something, you can just do small, brief exercises like chair squats or like strength training or like a little wall sit. And we know that physical frailty really accelerates aging and promotes cognitive frailty as well. So just thinking about the importance of strength training and muscle, combating that sarcopenia, which happens as we age. There's a great prescription pad from the American College of Sports Medicine. This exercise is medicine prescription that you can use in your office if so inclined. All right, so nutrition, I'm going to kind of speed up. So we know that ultra processed foods we're overfed and undernourished in America. And this is an article just summarizing that you see up here. And then, there's the most compelling evidence, I would say, for whole food plant forward with marine-based omega-3s. And I'm not going to go, there's a sort of vicious cycle that we want to try to combat around obesity and weight gain, and how it's much harder to exercise, and how there's this aggressive marketing in America around unhealthy foods. So what should our plates look like? Well, ideally, what they look like is that they're about half fruits, veg, beans, greens, nuts, seeds, and some fiber and protein. So lots and lots of fiber in here, about a quarter protein, legumes, protein, and then whole grains, as you see both here in Canada or from the Harvard School of Public Health. But let's not forget, it has to be delicious. It has to be culturally, and familially kind of palatable. And there was a recent study that came out, the Cosmos study. There were a number of, actually 3 cognitive studies within Cosmos. And initially they were looking at the benefits of cocoa, which they didn't find a benefit for. However, in these 3 cognitive studies within Cosmos, in this recent meta-analysis, they found that elderly people who took this Centrum Silver, effectively a multivitamin and mineral supplementation, versus placebo, had better cognition over, I think, it was 2 years. So, if the person is not getting adequate nutrition from their diet, they could add Centrum Silver. This is the initial study by Martha Claire Morris and her group, looking at the MIND diet, almost 1,000 people, where there was a 53% reduction in incidence of dementia over almost 5 years. This has been studied subsequently in a recent clinical trial that I've summarized here. And I think I wouldn't make too much personally of this trial, which did not replicate the benefit, because the control diet, people met with nutritionists and they were really taught about healthy food. So it may not be the MIND diet per se, but understanding that you have to have lots of fiber, lots of fruits and vegetables. So there wasn't a significant difference in this study, but it may have been underpowered, and people got the nutrition counseling to learn how to eat better in the control group. So, all right. So, again, in terms of cultural humility, there's a variety of traditional diets that you can see here through Old Ways and other websites to get these recommendations around fruits and veg. And we also know that these diets really can increase life expectancy over time. And the largest gains, as I've said, are really for the legumes, the whole grains, the nuts, and reducing the red meat and the processed meat. Again, how do we implement? We want to be respectful of preferences, sometimes working with a nutritionist, sometimes it's through teaching kitchen collaboratives. I was just at a conference and it was shared there, and I think it's very apt that teaching medical students or residents or clinicians or patients how to eat healthily and cook without teaching them how to cook in an actual teaching kitchen is like trying to teach somebody to swim without having them go into the water. So I think we're starting to really change our thinking about how to support people around these pillars of health to promote cognitive health, brain health, and health span. All right. And, thinking about incremental change, what might you want to add in a harm reduction model as opposed to just coming in there saying, you got to get this out or that out. And then exploring with different textures and spices. I mean, there's such a beautiful abundance in terms of the biodiversity and so good for the microbiome as well. And, and then just that social factor of sitting with people and having a meal really can be enriching. And here's 2 different websites, the old ways, as I said, and then Gaples, which really connects personal and planetary health in a deep way and has a lot of free content if you're interested. Okay, so cognitive training, many studies demonstrating the importance of cognitive reserve, lifelong learning, cognitive training, stimulation. Here we see just a benefit from all of them. So how do we do it? How do we stay active over time? Well, the things that have been studied most extensively are novelty within a social group is really enriching. And then speed has been shown to be beneficial as well. So you could learn a new card game, a new language, a new instrument, a new way of dancing, and then activities, as I said, in that social group setting are really enriching as well. And then, as I said, using processing speed, so pickleball or table tennis or whatever you want to do. This is just a really great website. www.heart.org has so many resources and is now also connected to the American Stroke Association. It's the same website. And they, instead of talking about Life Simple 7, are talking about the Essential 8, which we've been touching upon. And here's just, I just took a picture of all of the, different areas that you can find resources on their site about. And then this is a paper that came out in the New England Journal in 2020, the Amarenko et al. That I've reviewed. But really, I think it's very important to make sure that in our patients who have had a TIA or a stroke, for secondary stroke prevention, we are really targeting that LDL of less than 70. And this is important not only for that stroke prevention, that secondary stroke prevention, but also for vascular dementia risk as well. Okay. And as we said earlier, the combination or these multimodal interventions tend to have, synergistic impact. So this is the finger study, which was published now some time ago in the Lancet, and people were identified because of their cardiometabolic and cardiovascular risk, and then they were randomized either to sort of a multimodal intervention where they got sort of nutrition recommendations and exercise and cognitive stimulation. And what you see is that the group who had the intervention actually had improvements in executive functioning and their neuropsychiatric battery and processing speed. There wasn't such a significant improvement in memory, and that's consistent with a number of studies. But really, if people have improved executive functioning and processing speed, that really promotes their independence over time. These were people who were not demented, and they stayed, cognitively intact over these 2 years. So what is a cognitive checklist? We want to make sure about micronutrient deficiencies and other problems, any lipid issues. Are they drinking, head injury, these anticholinergics or harmful medications, untreated sleep apnea, and so forth. And we know, and Vivek Murtry has written really very eloquently about this kind of loneliness epidemic that can be really lethal and can sort of contribute to that accelerated aging and dementia. And conversely, or obversely, I think, mindset around aging and connection, social connection is really important. So these positive beliefs about, I want to be a grandparent, I have these positive associations are neuroprotective. And I've shown this data before, but it's about 4,000 people over a couple of years, actually 4 years or so. And people who had positive associations about aging had a lower, significantly lower dementia incidence. These mind-body interventions such as Qigong or yoga or Tai Chi have been demonstrated to reduce neuroinflammation in many, many meta-analyses and can really be helpful in terms of stress resilience and then, what is our purpose in life? How can we engage with patients around this purpose, purposeful, meaningful impact? What really matters, again, around the 5M, that can be very enlivening for people. And then around this sustained behavior change to kind of moderate the risk, what is, why is this important to you? And how confident are you to do it? And how can we set you up for success? So in our kind of summarizing and ending this, we want to make sure that we're deprescribing medications that are harmful, particularly those that are sedating or anticholinergic, that we're really optimizing all perceptual processing, such as identifying and treating hearing loss and vision, and combating frailty and getting people to sleep as well as possible. And then these other, I'm not going to read them. We've talked, I think, at length. And then we were very excited about part of our SMA is to incorporate teaching with the Teaching Kitchen Collaborative and send ingredients to our participants who are going to cook along with us. And I'm going to now stop, I think, this share. And we're super delighted. We'll have questions at the end, but we're super delighted that we have Dr. Jacob Mirsky, and he is a primary care physician at the Massachusetts General Hospital Revere Health Center. And Dr. Mirsky views healthy lifestyle changes through patient education and empowerment as the cornerstone of health. In addition to his primary care practice, he leads lifestyle medicine group medical visits, also called shared medical appointments, in primary care for symptom management and disease prevention. Dr. Mirsky co-founded and is the medical director of the MGH Division of General Internal Medicine Healthy Lifestyle Program, or HELP. The HELP has a vision of establishing healthy lifestyle change as the standard of care for preventing and treating chronic disease. He also serves as the assistant course director for Harvard Medical School's Herbert Benson MD course in mind-body medicine, and he is the MGH representative on the American College of Lifestyle Medicine's Health Systems Council. So it's really fantastic that he's able to share with you his perspective as a primary care physician in how he really addresses lifestyle change in an innovative care model. Thank you so much. Okay.
Thanks, Nancy. Appreciate being here.
We'll stop the share here. Okay. Yeah.
Everyone hear me okay? Yeah, good. I don't know how sound waves transfer over the continental U.S., but I'm in the Boston area. It is not a sunny afternoon here. It's definitely not warm, but I'm in clinic, and so unfortunately, I only have a few minutes to share with you all. Sorry, I've been off screen. I'm just cleaning up my inbox with 66 minutes left before 5 on Friday. Anyways, really delighted to be here. I very recently connected with Nancy to talk about the shared medical appointment programming that we do. And we actually are working very closely with the McCant Center that Nancy referenced and finding ways to integrate the brain care score into what we do. So I'm just going to give a brief presentation. I usually run through the slides pretty quickly, but if you have any questions along the way, feel free to just shout out. Happy to stop at any point. But I was hoping just to spend about 10 minutes or so talking about our program. As I think Nancy very well prepared for us, the reason that I'm talking about our program and the lifestyle medicine program came into be is with this fundamental recognition that in primary care, we deal with many patients who have chronic diseases, and in fact, almost half the patients that in the US who have a chronic disease actually have at least two. And we know, as was just briefly talked about in a lot of different ways, that many of the contributing factors to early death is directly related to lifestyle. And many of the guidelines clearly emphasize that lifestyle change should be the first step in managing chronic disease. So this is where lifestyle medicine comes into play, and many of the suggestions that Nancy was just very eloquently talking about. So I'll transition into kind of what we've actually done to take these recommendations and put them into practice. The vision for our healthy lifestyle program was to really create a healthy lifestyle change as a standard of care for chronic disease prevention, as it relates to dementia, certainly, but also for the treatment of chronic disease, which you could think of as the risk factors for neurocognitive decline as well. So the hub of our programming is virtual group visits, medical visits, also called shared medical appointments. I'll go into a little bit more detail about what those are in just a moment. This is really the hub of our program, and then we've attached a lot of other parts to our program, including health and wellness coaching to offer patients more individualized attention to make behavior change goals. We have remote monitoring for blood pressure. In my clinic in Revere, Massachusetts, we've incorporated a plant-based food pantry and teaching kitchen, and we also have virtual resources as well. So let me just share a bit about what virtual group visits are. These have many different names, including virtual group visits, shared medical appointments, group medical visits, etc. But the crux, for those of you who aren't familiar, is a group medical visit is a care delivery strategy that replaces the one-on-one visit that we're all familiar with. So instead of seeing 6 patients back to back to back to back to back in clinic, the idea is that you put all 6 patients in the same room, either a virtual room or a Zoom room or in-person a conference room with the same provider. The way that we run our group medical visits is that the first half of a 60-minute visit is focused on didactics. This ranges for a wide array of topics. This is a much more efficient way to get education about chronic disease prevention and treatment out into the world. This should be intuitive, right? Like when we go to school as a kindergartner all the way up through graduate school, usually we don't receive intensive one-on-one education. The standard approach, I'd say, for educating us in our society is in a group setting. So this leverages what we know works well from an educational perspective. But then in the second half of the group visits, we switch to this one-on-one individual check-in model. This is really important because every individual conversation that takes place between the provider and, in our model, the health and wellness coach as well, with the patient, that individual conversation is what we're then able to bill as an individual medical visit. So every patient is receiving individualized medical care in the context of the group visit. And while we touch base with every single patient, every other patient is listening to benefit from what we're doing. We then offer health and wellness coaching to surround these visits, to recognize that a 2 or 3 or 4 minute check-in with each patient is really insufficient to effectively move the needle for a lot of patients. So incorporating health and wellness coaching both during our groups, but then after the group visits as well, is really critical. So this is fundamentally our model. We have virtual group visits that have a provider, a billing provider, a physician or nurse practitioner, a health and wellness coach. They meet with multiple patients at the same time. After the group visit, coaches are able to do one-on-one coaching, and then patients return to additional group visits as time goes on. Our program has expanded quite a bit over the years. We actually had our origins all the way back in 2000. My colleague Stephanie Eisenstadt began a group visit model in 2000 that was actually focused on women's health. This was taking advantage of early practice change and research in the 1990s focused on group visits. Then there was a growing interest in group visits in the 2010s and teens. I came in on 2018 with the goal of expanding our group programming, and then really everything switched for us during COVID when we transitioned to virtual. So we developed the Healthy Lifestyle Program as a primary care wide, MGH primary care wide initiative. In 2020, we had 5 additional providers that we trained. Things went really well. We ultimately trained several more providers and hired more health and wellness coaches. And then we've basically matured our program in 2023 to now be at the point where we have 17 providers who are running group medical visits across MGH primary care. We have 5 health and wellness coaches, and we have in addition to our standard English-based programming, we also have providers and health coach and one health coach who also speak Spanish, and so we offer our programs, some of our programming in Spanish. Our flagship program, and Nancy, I think you set this up nicely, is hypertension focused. So our flagship program is a 4-part virtual group visit series on hypertension. We give patients blood pressure cuffs and incorporate remote monitoring for that. We also, this month, actually, in honor of Heart Month, launched a heart health 4-part series focused on hyperlipidemia. We also have a series on prediabetes and diabetes, brain care, which I'll share a little bit more in just a moment, stress reduction, nutrition, culinary medicine, and insomnia. So as we've built up this programming, and one takeaway that I would love for you all to think about after today's conversation is that there are many, many different benefits to virtual group visits. It is clearly, definitively, a more satisfying healthcare experience for many patients. And we receive feedback forms after all of our groups, and consistently shows that this is a very high yield, high enjoyment way of a patient engaging not only with their healthcare provider, but also with a coach and other patients. It's an excellent way to provide guideline-driven care, especially for those of us who are used to very quickly running from patient to patient to patient. And I would say, I think it's fair to say, inefficiently covering way too many topics than a 15, 30, or even 60-minute visit can allow. As a result, because patients love it and you're delivering high quality care, actually, this is a great way to build provider joy. It's certainly the most enjoyable part of my clinical work that I do. Many of our providers have stuck on. We actually haven't lost any of our providers that we've trained. No one has stopped because they haven't enjoyed it. And in fact, many people say that's the best part of their career. And then from more of a business side, it's a great care delivery strategy because it increases access. You're able to see 5, 6, 7, 10, even more than 10 patients in an hour, as opposed to maybe 2 or 3. And because you're able to see more patients, you're able to bill for more patients. These are billed at a 99213 or 99214 level for billing providers. So you're getting a significant multiple on normal revenue that comes in. I'll just share briefly that we've done some research on our program as it's grown. Most recently, a couple months ago, we published a survey study of patients who came in during COVID. It showed that many patients who came in had a significantly better than expected experience in our program, and that was markedly higher for those patients who attended over 5 or more groups. We also asked I learned as I was doing this research study that the best question you can ask in program development is, would you recommend this to a family or friend? I think it applies to the commercial world or the for-profit world as well. But anyways, over 90% of our patients would recommend it. And for those who are really engaged, it came to 5 or more, it was 98%. We also asked patients about the perceived health benefits of attending our programming. And I think to the points that were brought up earlier about how expansive brain health, but really chronic disease management can be when you talk about lifestyle factors across the board. The benefits of these types of programs is you can touch on a number of them over time, and that was verified in the research that we did. So in general, patients who attended the program endorsed eating healthier, increasing physical activity, losing weight, reducing stress, et cetera. And we saw about a doubling of the effect for people who came to more groups. Of course, there are lots of potential confounders in how you interpret that, but just to say that patients who come to a lot of groups are strongly endorsing significant benefits. We also, as I mentioned, have made the hypertension program specifically the focus of our research. So we published this study 2 years ago now, where we looked at the home blood pressure readings before our 4-part series. Then we delivered the 4-part series and analyzed the blood pressure after the 4-part series. This is an uncontrolled study. Almost every group visit research study, actually, I think every group visit research study I've ever looked at has not had a control group, and there's not a lot of funding in this space. But anyways, with that caveat, we did see reductions in blood pressures from a pre-post perspective, so systolic and diastolic. And in many programs that are focused on blood pressure reduction, it's actually usually due to medication increases. Like there's a lot of pharmacy-driven group visits and other program as well. We saw this reduction in blood pressure actually in the setting of deprescribing. So when you look at the 2 bars on the left here, the dark green one shows that during the program, 59% of the patients actually had one of their medications deprescribed because they were making healthy lifestyle changes that lowered their blood pressures. And then after the program, as part of usual care, another 44% of patients had additional blood pressure medication reductions, simply because they were presumably continuing their healthy lifestyle journey. During the program, there were very few patients who increased their medicines. It's not that we're against doing this, but especially in the setting of polypharmacy and thinking about reducing side effects, it was actually quite encouraging that many patients didn't increase it. And even as part of usual care, most patients didn't even increase their blood pressure afterwards. I'll pivot now just to talk briefly about our brain care series. As mentioned, this is a collaboration with the McCants Center. You might recall this is their logo up top, the McCants Center. So we developed a collaboration with them we started a collaboration with them in 2022. And their goal, as it sounds like, I think is shared in the talk from earlier, was to really think about establishing sustainable practices for promoting brain care in a primary care setting. So they had developed this brain care score. They'd done research on it. They just had the updated research you showed, Nancy, as well, from the UK Biobank. But the score itself is not a care delivery strategy. It is a tool that can be used in a care delivery strategy, but it itself is not a care delivery strategy. So we worked with them to incorporate the information from the brain care score into a 4-part series, similar to our hypertension program. And that's what we've been running now. We've had, I think, about 150 patients who've come through that program over the past 2 years. And now we're beginning to put together a research study for that. So as you can see in the first part of the 4-part series, they're introduced to brain health. And then session 2, 3, and 4 are the 3 components of the brain care score, where we really go into detail about everything that you just mentioned, Nancy. We talk about nutrition, we talk about physical activity, we talk about blood pressure, we talk about stress, alcohol, cigarettes. Everything that's in the brain care score has a few dedicated slides in our curriculum so that patients really learn a lot about what's going on. So in total, the 4-part brain care score virtual group visit series has education on brain health and the brain care score. Individuals receive the brain care score as part of participation. They have the group-based coaching that I mentioned earlier, and then they're able to do individual coaching afterwards. I put a number of patient quotes in here because it's very tempting, but I know they're not necessarily fun to read. So I'll just highlight in green what some of the patients have said, that patients really appreciate that information is about keeping healthy. They're learning about health in a community is powerful. And on the third quote, grounding in brain science and function was helpful as well. Patients also reported that they like seeing their brain care score. Again, working as a community, building this connection with other people is motivating. And then I think I should frame the last quote that says it's an incredible program to offer within primary care. And something that we consistently see is that people want more and more of this. So I'll pause there. Happy to answer any questions. I know it's a lot of material to cover, but usually there are a lot of questions that come up when talking about this. So happy to answer anything that came up.
Thank you so much. Yeah, and thank you for stopping the share. Thank you so much for that great overview and the tremendous work that you're doing. I think I'm curious to hear any questions from primary care about this, innovative care model, or perhaps about anything else. I imagine there's quite a few questions.
Hi, my name is Angela. I'm a family nurse practitioner at a community health center. I would love to hear more about kind of how this virtual group visit started and kind of like the history of it.
Yeah, so Stephanie Eisenstadt, as I mentioned earlier, Dr. Eisenstadt was a primary care doctor almost 25 years ago who had an interest in behavior change and started the initial group visits at MGH that were focused on diabetes. She incorporated in those groups a health psychologist, if I remember correctly, and they really focused on coping strategies around diabetes. It was not strictly about nutrition and physical activity. It was much more about coping strategies and self-empowerment. And Dr. Eisenstadt was a major champion of this work for a decade. She actually, in 2012, she published, I guess, self-published in a way through MGH, a PDF that many people use and is available online, that goes over all the nuts and bolts of group visits. And so she really went on a mission to spread the word about group medical visits. And one of her disciples, although there were many out in the world, one of them was at MGH. And so she, in a way, the torch was passed to Dr. Helen Delicatsios. Her interest was in culinary medicine, and she's also a PCP. She started running group visits in her practice, cooking along with patients, and was actually one of the early culinary medicine providers in the country as well. So that was kind of going along, and then Helen connected with Amy Wheeler, who's my boss in Revere, and Amy was like, hey, I want to do that too. And so she started some group visits on obesity, but all of these were just effectively one-off groups. They were doing it themselves with a bare bones staff. It was not part of a larger program. But when I joined, I was really interested in using this model to focus on chronic disease care. It's in residency, it just became a passion of mine, in particular lifestyle change. So when I joined the Revere practice, I specifically wanted to spend time with patients focusing on stress management practices. And then I built curricula around hypertension and diabetes. And from there, it's expanded. Hopefully that addresses it.
Yeah, that's great. Thank you so much.
Hi, Jacob. My name's Anna Trancales. I'm actually involved in residency here in Tacoma, Washington. We do get a lot of questions, from the new doctors about lifestyle medicine. So I find this very interesting. In terms of setting this up, for you and your partners, do you give additional training in terms of setting up these virtual visits for the providers?
Do you mean within MGH or outside of MGH?
Yeah. Mm-hmm.
Yeah, so this was within MGH. I mean, this is why, I don't know if you can tell, this is why I developed a lot of gray hair during COVID. It was not because of COVID, it was because of expanding this program. Yeah, so we initially, so a lot of our work was actually based on some really pioneering work that an amazing group visit advocate named Dr. Marianne Samego at Cleveland Clinic, work that she had done. So Cleveland Clinic is by far the national leader in group visits. And Marianne, very interestingly, had an approach of training the trainer to basically create this whole hospital-wide system of people who she would briefly train to run group visits, but then they were really empowered to run them themselves. We kind of wanted to do that, but that didn't work with my personality style, and also with, I think, the needs of the hospital system, because group visits require a lot of administrative support. There are a lot of logistical questions to running them. And so we tried to do something like that. And we did kind of some brief trainings and said, good luck, but in a number of cases, it never got off the ground. So early on in our pilot during COVID, we made the decision to transition to a hub and spoke model, where we centralized a training program, brief, but a training program, documentation, a workflow for working with the administrative staff to block schedules and to schedule patients. We then centralized the recruitment strategy. And so effectively, we have taken on a lot of it ourselves as a team, and that's allowed us to grow, because then we have more people under our umbrella. So we were able to get a bigger and bigger budget. But that is a traditionally very tricky part of the early phases for people who want to do group visits, is trying to decide whether you're kind of by yourself figuring it out or part of a larger program. Of course, there's strengths and weaknesses to both, but usually having some sort of centralized support is really helpful.
Thank you.
Thank you. Yeah, any other questions or comments? I'm curious from our community, if anyone wants to share their experience with group visits. If they've tried them in primary care, any other context.
Hi, this is Karen Hayes. I'm the caregiver representative for Echo Dementia for this group. But in my other life, I'm a nurse midwife, and we've been doing group prenatal visits for probably 10 years now, various practices in Washington State. And yes, there are a lot of different kinds of tasks that go into grouping women and getting the women of certain gestations in the room and so forth. And some practices have made group prenatal care for certain ethnicities of women, like Somali women or so forth, if there's enough in that practice, and to bring people together. And I think a couple of the advantages of that are, one, it's hard to meet people with your similar situation sometimes, especially in dementia where there's so much stigma and secrecy, particularly in the early phases. So I think just bringing people together with, a no stigma group. And I know the early groups my husband and I participated in, we still have, or my husband's passed now, but we still have friends from that group that we then met outside of group and made our own community. That's one. And I think the other advantage is for people who are introverts, Nancy and her talking so much about social engagement and being social, and, with a quarter to a third of people considering themselves to be introverts, and really difficult for them to reach out and make friends and spend time with people, and needing alone time to recharge as opposed to being with people to recharge. I think having group visits just sort of as part of the clinical scenario can crack the ice on that a little bit, that it's normalized, it's expected, it's for a specific amount of time with specific people. You can participate as much or as little as you want in terms of sharing. So I'd say for the introverts that helps as well.
Thanks, Karen. And I think you're right that that sense of feeling in a community where there are kind of similar challenges, whether it's the chronic condition that you're living with, and then the support and potential accountability, it can really be very impactful. And then, the time and the sense of belonging and the lack of isolation. Brock, I see your hand up. And if you want to introduce yourself,
Yeah, so thanks so much. This was an amazing talk, both of you. So I'm Brock Gaster. I'm a primary care doctor at the University of Washington. I run a training program for primary care on dementia. And I've actually been in conversation with Laura Frayne at the Brigham about maybe bringing some of this training to MGH and Brigham primary care. The question that you must get all the time is like, do you really need to go to medical school to sort of run these visits? And I think, like, have you, like, how much of it is, like, for sure, like an MD sort of activity versus a activity that could be sort of done by somebody else?
Yeah, I don't get that question as much as I used to, I guess. But what I would say is I'm a primary care doc, and about half of my time is clinical. And I would say 90 to 95% of the stuff that I do, I don't think I needed to go to medical school to do. Like the last patient I saw today had an inclusion cyst on his neck, and I mean, okay. So I think the framework that I come from is like the primary care system in the US is broken, and part and parcel of that is we do a lot of work that's not that doesn't take advantage of the training that we have. But what I would say is, given how prevalent lifestyle dependent chronic conditions are, and B, given how like directly that falls under the purview of what primary care does, I think the best use of our training, our time, our energy is to deliver high quality chronic disease prevention and care approaches. So I think actually the best use of my time is focusing on salt restriction for hypertension. I mean, I think that's probably where I'm going to have the biggest bang for the buck. I think also there is quite a bit of skill that's needed to run a group visit, not necessarily something I learned in med school. But I think there are a lot of clinical skills from clinical training that directly go into group medical visits around patient education and motivational interviewing and things that you've talked about as well. So that's my general response.
Mm-hmm.
And then I think that there's another layer to it as well, which is that this does not need to be physician driven. And we have nurse practitioners who lead groups, and they do a fabulous job. There are physician assistants that lead group medical visits and can bill for them as well. It ends up being somewhat of a practical question, which is that for group visits to take off, let's just assume for argument's sake that group visits are a far superior approach to clinical care than one-on-one visits. To actually make them work in a fee-for-service model, they have to be done by billing providers that will get enough revenue to sustain the programming. I mean, having said that, our program loses money for the hospital, but that's because we're primary care. Like every day I show up for primary care, I lose money for the hospital. So that's just, again, how the US healthcare system's broken. But yeah, I think in many ways to bill for these, there has to be revenue generation associated with it. And so that's where the MD, NP, PA need comes from, another part of it.
Yeah, I totally agree with that. And I will say that what we are trying to do at our Center for Healthy Aging is make this an integral part of the care that we provide because of the need for the chronic disease care and management and its impact on cognition and brain health. There are programs, and Emma Dodson runs a fantastic series of 8 shared medical appointments. And it's part of our program that folks, when they come and see us, understand that this is a component of their team-based comprehensive care. So that said, there are programs, and I'm curious from the community if any of you are referring to, for example, the community services through the Y, which are not physician-led, such as Lose to Win, such as the Diabetes Prevention Program, because those are also fantastic community-based programs. If you're not gonna, maybe you don't have the bandwidth, or maybe you don't think you can get the efficiency, or maybe you're skeptical of the joy that these types of visits give to the person who's engaging in them as the provider, but there are other things out there that can really help in terms of chronic disease management through the Y. So would anybody want to unmute themselves and share an experience there? I mean, I can vouch for them. I've referred folks. We have in our family medicine program, and through Epic, a direct referral. They're free to patients for the diabetes prevention program. I don't think Lose to Win is covered by insurance at the current time, but it's really a very small amount. So that's another way to consider this. I'm also curious if anyone in our community, is tempted to consider incorporating this model in their practice, understanding that it does require a team, complex scheduling. And I want to make another point, Jacob, which I think you said, but I want to really underscore. So when you spoke about that one-on-one, that is in the setting of the group visit. So the other people in the group are learning from and hearing about the concern, resonating with that, not feeling alone. So I don't know if you want to add. So it's a one-on-one with observers in the group context, which enriches the experience.
Yes, definitely. There are a number of things to say about that component specifically. One, I would say, is that to your point directly, it absolutely is something that many patients comment on, and there's actually a good literature around this as well, is that the connection with other patients, seeing that they're not the only one, learning from what other people have to say, that's actually really, really important for many patients. The second thing to say is that it's really important from a billing perspective. Different systems and billing folks, and I mean, for the insurance side isn't really much of an issue because these almost always get covered, but billing teams at different health systems can have varying levels of comfort with this. So I think our billing folks are fairly conservative. So we need the one-on-one visit specifically for patients to create some sort of action plan, care plan that we can document as an individual visit. And so in that sense, it's also really important there. And then just one related comment is that I used to actually, one of the most frequent questions I used to get was around confidentiality and, would people want to share information? And it turns out, so logistically, everyone who joins a group visit should give consent to join a group visit, and HIPAA should be discussed. But actually, there's a self-selection process that people who come to groups are probably the ones who want to share in groups. Like, they know that it's a group visit. So confidentiality is almost never a concern in practice.
Thank you. Right. So yes, we are, before the group visit, of course, signing that consent form where you consent to have a visit with observers. And then, as you say, for a self-selection or for a number of reasons, people really actually, I think it's also witnessing and being heard and being seen in the group. We have 3 minutes. I saw a hand go. Trang.
Yes, hi. Great talk from both of you. Thank you. I have a question about the group visit. What is the average age in your group visit? The average age of the patient?
Right. Jacob, do you want to answer, and then I'll answer as well?
Sure. Yeah. So we have looked at this many ways at different times, and ballpark, our average age is early 60s. And demographically, our most common demographic is a white woman. We do have patients that range, our age range is basically 20 to, I think 94 was the oldest patient we had. And, we have certainly have men who come, and MGH, just the primary care population in general is overwhelmingly white. So we don't have a lot of non-white patients, broadly speaking, but we do, our demographics racially and ethnically is essentially pretty similar to what the MGH primary care is as a whole. And I'll say, just historically, as I've looked through all the research on this, overwhelmingly women are more likely to come to group visits. And you look at the research studies, it's overwhelmingly women.
Mm-hmm. Okay, well, I will just briefly bring up the last couple of slides, feel free while I'm doing this to ask any remaining questions. I put in the chat the diabetes prevention program through the Y if you're interested. Just a reminder that lastly, you can text this number if you're at UW, text 8574, please. For your CME, and then here's our next session coming up. And please don't forget to fill out that survey. And lastly, thank you so much, Dr. Jacob Mirsky, for this fantastic work and your amazing presentation. And thank you all in the community for joining. And we will see you guys in 2 weeks.